Thank you, everyone. My name is Reina Patel, as Sadeep said, and I'm super excited to be here and use this opportunity to connect with many of you. Um, the topic today is a little bit more of a thought piece, so I really welcome questions, comments, engagement from you throughout the talk, but definitely at the end, because this is a lot of my thinking and reflections as I am growing as an investigator. So no conflicts of interest. We've got a long agenda, so let's get started, starting off by acknowledgements. Land acknowledgement for Birmingham to the Muskogee Creek and Shawnee people. And I also include the link for a really great resource from Canada that generates these maps. So if you are ever giving talks and want to do a land acknowledgement for somewhere else, they are really great resource. Thank you to Epi for this invitation, all the various collaborators in and around the one data resource I'm going to talk about called N3C, and then the University of Washington Center for AIDS Research, CFAR, that funded some of the community engagement work that I'll be presenting today, and the Parent R1 and some of the supplemental funders for this work. Since I'm new to you all, I thought I would plug in a few slides about myself. So I was born in the great city of Chicago, but at the age of 6, my family moved back to India, thinking they were going to live there permanently. So we moved to that part of India, which is called Gujarat. That's a picture of me with my cousins in front of our home, my family's home. And then as you know, came back at age 12, back to the US. And so living and growing up in India was really a part of my formative years. And I was so eager to go back as a young adult. I joined this HIV/AIDS prevention education work for a group started by Vivek Murthy called Visions 2020, where we were doing prevention education in schools in India. And so here's a picture of us working with kids to put on a condom on an empty Coca-Cola bottle, of course. And that inspired me to go back and do more work in India. I work with rural development NGOs, teaching children, learning along the way. And then I volunteered to work with a nonprofit to do HIV/AIDS prevention education in Arusha, Tanzania. This was my first time working in sub-Saharan Africa. And it was at that time where I decided, as much as I loved working in India and had all the cultural competency, humility to work there, I really felt like there was a large need in sub-Saharan Africa at the time that I wanted to help fill. And so since then, I've been working largely there. During medical school, I got a chance to work with colleagues in Zimbabwe. So that's the no food, no jobs, no medicine, no Mugabe. Graffiti you see there. Found my partner in medical school. This is our first kid, our daughter, our second kid, a boy, and a little more pictures about our goofy family. I've never been more humbled in my life before than being a parent. So they keep it real, very real. And Sadeep already mentioned some of my educational background. Just to highlight, I've had training in sociology, and so a lot of the work I do is mixed methods. So I rely on qualitative and quantitative data collection methods. And here's an overview of research portfolio. As Sadeep mentioned, we're eager in Department of Medicine and Division of Infectious Disease to collaborate with so many of you and take on trainees. And so I wanted to just share this slide to talk about the different projects. I've started off in HIV, reproductive health, and pharmacology. So we have cohort studies, PK, pharmacokinetic PK studies, pharmacovigilance, PV studies in this area. The second bullet has to do with HIV treatment and point of care technologies in low middle income countries, particularly for pregnant postpartum women that had a sister project in children. And we did also point of care HIV drug resistance testing, which is really novel and interesting work. So a lot of opportunities to do secondary data analyses with those data sets where the data is already collected. We have another work stream working on HIV testing among African immigrants in the US. So this started with work in Seattle, which has a large African immigrant population. And we've had different phases of work. We're now at what we call Harambe 4.0, where we're actually looking to expand work in Birmingham since I've been here. And interestingly enough, one of the stigma reduction workshops that we've adapted in Seattle actually comes from a colleague, Pamela Jane Foster at University of Alabama, who adapted a Ghanaian version for African-American rural churches in Alabama. And we adapted it further for African immigrant and Muslim communities in Seattle. And now we're trying to, bring it back to Birmingham. So all these amazing complex connections. And that's definitely a project where we're eager to take on individuals who have, local connections and roots to work with us on that. And the last, which is what I'll be talking mostly today about, is like everyone in public health, when COVID hit, so many of us pivoted towards including COVID research, and we did too through this big data resource called N3C, and we've been doing some really interesting community engagement work here. So I want to talk about data justice as the bigger thought project here. We know there are biases in health data specifically, and so what would data justice in health data represent? And some of my thinking is inspired by this documentary, Coded Bias, done by a PhD student at MIT. I don't think she was working on anything health related, but as part of her PhD, simply the face recognition software she needed to use to log into some of the software her team was using would not identify her. She is Black, of African immigrant background, but did readily for all her non-Black colleagues. And so she has started a nonprofit called Algorithm Justice, which is really keen on understanding some of the racial biases that exist in large data, including AI. And so, that coupled with, there's a colleague who works in health economics, Obermeyer at Berkeley, who, on face value, when you look at the first graph, you see that the spending doesn't change so much between Black and white expenditures for Medicare or Medicaid. I think it's even I'm having a hard time reading that. I think it's Medicaid expenditures aren't different, but when you adjust or account for the clinical comorbidity burden that exists among African Americans, which is higher compared to whites, you do see, ironically, the expenditures are actually lower among African American populations. So it's this idea that, we need to be careful of how we interpret data, how we think about the data, where it's coming from, and what biases are baked into some of the data. And so I include a website here from a nonprofit in Oregon that talks about, data justice includes redressing data collection and dissemination, because these have historically been used in ways that have harmed minoritized communities. What I want to add is, how do we walk a few more steps before that in data analysis itself? And so in conceptualizing your study question, in thinking about the modeling methods, the parameterization of those models, the choices you use for those, et cetera, like how do we think in the data analytics space about what data justice itself means? And so let's get started on N3C. So a little bit of background, it's called the National COVID Cohort Collaborative. UAB is a participating data partner site for this collaboration. It's a centralized, secure portal hosted by the NIH. So very interesting. You have to do all these onboarding, like how to escape a fire in one of the Bethesda buildings, and you're like, how is this relevant? But it's part of the NIH mechanism. And the CTSA use existing CTSIs. I think ours is called CCTS, to get this jump started. March of 2020, when COVID first happened. It's the largest national HIPAA limited data set in the country ever. So really powerful. form of collaboration. And the main thing that's different is the first side shows you federated approaches to data collection. And so my understanding is the CDC, for example, uses that federated approach where each jurisdiction collects the data in their own ways, and they have governance over how to share that data. The federal CDC requests data, but the local jurisdiction has a lot of control over it. And some of the analytics are run locally and the data is aggregated. Here is a very different approach. It's a centralized analytics approach. So every data partner site dumps their data into one big central repository. The data is standardized, harmonized, and then put forth out for everyone to use at the same time on that central repository. So it's been, for those who work in this area, I think a very unique and different collaborative model. And so, as I mentioned, there are different data partners. NIH is the central governance body here. There are different data ontologies that are used. OMOP, PCORNet, those are some of the more common popular ones. And then they're acquired and harmonized and then given back to people to use. And so I represent, one of these people icons here, of a clinician researcher who wants to use the data for research. There's also synthetic data available. Sorry, I think. Yeah, okay. There's also synthetic data available and really interesting work coming out of this N3C data set for how helpful synthetic data can be, which is a new area for me to learn about. So N3C is organized on the data user side among many domain teams. They are topic related. So I help co-lead the immunosuppressed and pregnancy domain teams. There's one on social determinants. There's one on aging, pediatrics, so forth. Then there are other logistics based domain teams, like the team that works on the dashboard, machine learning, and a publication committee, as well as people who work on data harmonization, ingestion, et cetera. It really is a very horizontal collaboration model. There are these maps are old now. I think probably actually a year old since I made these slides first. But there's data from over 20 million patients from over 80 plus sites that have active data being deposited in the repository, and the researchers are from over 400 institutions. They have a similar publication map that shows papers where co-authors are from different institutions, and it's a huge web of a mess, but only to highlight that indeed it's a highly collaborative environment. This is what the dashboard looks like. This is publicly facing, so you can pull it up right now. This is what the enclave, N3C enclave, looks like. So you log in. You have to log in. You can never download a data set onto your own hard drive. You do all the computation analytics on this cloud-based server system, which is supported by a company called Palantir. So you have to log in and do all your work, coding, et cetera, which is, again, another way that most of us are used to doing analyses, and has lots of limitations, particularly regarding the ability of the platform to support the tremendous amount of data. So this tells you, so over 20 patients with 28 billion rows of data. When we do like machine learning or multiple imputations work in this platform, it takes like days for it to run, and invariably crashes and et cetera. So lots of limitations, but you can imagine the power of being able to analyze data for 20 plus million people at the same time. I have some links here for those of you who are curious about what N3C is and different related resources. I'm going to switch to talking about some of our community engagement work. And so, I come from a field of HIV where community engagement historically has played a really large role and has a strong activism background. What's really interesting is that less of this exists in big data science. When you think of big data science, you're probably thinking, all those data scientists, at most bioinformaticians, clinicians, working together. But leaning from our HIV work, we were thinking, we still need active community voices represented in this work. So we were really grateful to get some supplemental funding to do this work, where we thought that we could definitely, we had an R01 that looked at the intersection of HIV, COVID, and social determinants of health, but we wanted to bring in these community engagement elements. And our goal was to improve the ability of both community partners and researchers to co-create the scientific agenda. And so these were some of our specific goals, and we've gotten down to number 4. So, one was identifying community leader, Rahel Schwartz, who has now gone on to be MPI on subsequent grants that we've submitted. And I think that's been a powerful transformation for me to see that our big data work now has a community engagement specialist as MPI. We've recruited community members to serve on our what we purposefully, intentionally call Scientific Advisory Committee. So just a side note, there's a spectrum of community engagement, and I, for one, shy away from using community advisory boards because often they're serving as consultation. And for me, more meaningful work moves towards a spectrum of true partnership. I'm not saying I'm there yet, a true partnership, but at least I'm at the collaboration middle ground where we're moving away simply from consultation to collaboration. So we've identified groups to join that. We've identified community-based organizations to do some of the qualitative work we've done. And then in September last month, we were poised to hold our workshop to do different things, including the policy brief work that we wanted to do. But Hurricane Francine hitting New Orleans, the day we were holding our workshop derailed it. So we've rescheduled to Atlanta in April of 2025. So stay tuned for that work. Our community engagement approach had 2 major prongs. One was the Scientific Advisory Committee, and the second was engaging community-based organizations to conduct focus group discussions. So this is our Scientific Advisory Leadership Group, Rahel, myself, and our coordinator, Shukri Hassan. These are a list of people. So on your left-hand side are the community members, and on the right side are other academics. I think more conventionally, when you're writing grants or doing projects, you might see a list like this, right? Topic experts from the country that you want to engage in your work. But we're really proud to say, we've been able to parallel that with community members who have, as much of lived experiences to contribute to this. That's not to say, one thing I wanted to highlight was that we explicitly compensated the community members for their time. If we had more funding, we would have loved to have done that for our scientific, quote unquote, scientific members too. But given the limited resources, we chose to prioritize compensating our community members. It convenes monthly. We just had our last session this month where we did a training session on how to write opinion editorials. So these are all sort of needs that our community members would identify that they would get value from working on this collaboration with us. So we were getting outside speakers who specialize in that to come and talk to our committee. We focused a lot on, if you remember, I said that one of the goals was to co-create a scientific agenda. So that was a lot of our initial meetings where we were talking about, okay, what are the research priorities in HIV, COVID, and social determinants of health, how to conceptualize structural racism, etc. And this work, the actual data collection was led by Stefan Wallace, who was the director of Office of Community Engagement at CFAR, and during the project period has unfortunately passed away, and supported by many students who were part of the group. And we did convenience sampling from Social Professional Network from Stefan, and approached 9 CBOs, 8 of whom agreed to work with us. We compensated them well to do the FGDs, and compensated participants. And it was really exciting for me. We were really hands off for this project. I've been part of other community engagement projects where we do data collection, in-depth interviews, focus groups, and we're doing a lot of the training and the materials and finding the facilitators. And this time we said, would you like to work with us? And you get to drive the boat. I will acknowledge it was one of my first times to really sort of let my tendency for control and power go in this situation. Each CBO chose their own facilitator. They took our suggested guide for the FGDs and adapted them themselves. We would join like a Zoom meeting with them before the FGD to like help adapt it for whatever they wanted. They did the administration of the questionnaires. They compensated the participants. We had no idea how any of that happened. They recruited, advertised, everything. It was basically them led. And we also used a minoritized person-owned transcription service to transcribe the transcripts from the recordings. We used thematic analysis and deduce, and we also did member check of our preliminary findings. And again, proud that we had money to compensate the individuals who are doing what we call member check. They're reading our transcripts and picking any discrepancies from what they recall, as well as the findings. These are the organizations we work with. So this project was focused a lot on HIV, as I mentioned. Characteristics of the 98 participants who filled out our survey. Not everyone did. And so you can see, largely younger folks, mostly Black individuals, pretty decent split between genders. And a lot of them were fairly educated and working in other sectors related to HIV service provision. So I'm not going to go into details, only to say, we found themes and we mapped it to the Healthy People 2030 framework of social determinants of health. So this highlights some of them. And, interesting element is the intersections within the social determinants of health. So obviously, built environment affects your ability to get transportation to work, to appointments, et cetera. So a lot of the work highlighted, or for immigrants, not wanting to jeopardize income and therefore their immigration status. So a lot of connections within the different domains. And this element that came up quite a bit, and we hadn't necessarily structured our guides to ask more about structural racism, but it came up quite a bit. And so we chose to dive into that separately, where, a lot of what our participants stressed was that there's a larger context of structural racism, even before you can start talking about SDOH factors influencing HIV, COVID, et cetera. And there were three main manifestations that people highlighted: this idea of lack of power and representation, which then, and this is a lot in both federal, national, and regional decision-making spaces that would then go on to lead to insufficient and weak structural resources. Differential access to resources that prioritize well-being of white communities over non-white communities, and a perpetuation of intergenerational mistrust and trauma, and how this specifically occurs in healthcare settings. So really powerful themes that helped our team think harder about, when we're working in SDOH, we need to think about these structural isms. And so racism is one of them, but the point about the larger context, that there are other isms, right? Like each one of us has this intersection of various social positions that inform who we are, how we work, how others perceive us. So people are talking about, like, yes, they're Black, but they're also trans. They're Black and immigrant, or they're female and Muslim. All these sort of intersecting identities or social positions go on to influence a lot of what they're actually experiencing. So some of the lessons we've learned are pretty obvious and probably common to others who do any community engaged work. Representation matters, that we had team members that really resonated with the communities we were trying to reach, helped tremendously. a lot of this relied on Stefan's existing relationships, and that was really helpful. The process matters. We were really proud, that we had member compensation for the community members in our scientific advisory committee, that we felt like we compensated the CBOs well for this work. We used minority-owned businesses whenever the opportunity arose. Some of the next steps for our work from the focus group data, our first paper on structural racism is under co-author review. We're doing a second paper on SDOH, and it's really interesting. How do you get community members to be co-authors on papers? I would love to hear what successes or failures you face. I can tell you, we faced many failures. It's not the usual culture where you're like, okay, here's the draft. Please give us your review back in 2 weeks. That doesn't necessarily work. So we're coming up with some interesting ways of having small group, individual one-on-one meetings. And this is more time intensive, you can argue, but at the end of the day, that's what's getting us more meaningful information. And we're doing interesting things, like we rewrite the paper without the discussion section written yet, shared with people to actually get their feedback on what they think are the highlights, right? Like, what are the elevator pitch points you want to highlight, get that feedback, and then write the discussion section to incorporate that. So anyways, I can tell you more examples of how we failed, but these are some of the ways that we are succeeding. One of the fundamental issues is how to sustain community engagement. I think we're finding it difficult. We have these monthly calls. Of course, not everyone is on every time. And then participation tapers off, and then we've run out of funding, right? So we don't feel comfortable asking people to give us their time without finding a way to compensate them. Okay, this is some of the data related work now that I wanted to switch to. And so the N3C has a social determinants of health domain team. This is led by Jimmy Fung, who shared this slide with me. And so they've done a lot of interesting work thinking about what are the, what population level frameworks you can use and how those map onto SDOH from the individual, community to health systems level. Here's a specific publication from their team lead, Cherise Madlock-Brown at Iowa University, where they look at specific data domains and variables that are available in N3C and how those map to the Healthy People 2030 framework of SDOH, as well as the socio-ecological framework of the level from individual, interpersonal, organizational to society policy levels. Some initial work from Cherise's group where they looked at county level SDOH variables and county level policies, and then COVID-19 outcomes, where they were able to show, for example, greater Black-white segregation was associated with greater number of COVID-19 cases and mortality. They've also done some really interesting work in understanding race, ethnicity, non-conformance in electronic health record repositories. So this graph here shows that the next, the second column, the second circle down, about 20% of the responses for race ethnicity had non-conforming data. This is a little bit shocking to me. 20% of missingness for race ethnicities, right? If we thought it's a missingness problem, is a pretty large amount. And that it's non-conforming. Non-conforming tells you there's some pre-existing structure, architecture that we're using, that we're mapping these onto. Well, so when you then dive into it deeper, some proportion it is truly missing, but a lot of them are things that work against communities of color. So they're multiracial groups. They're they're more granular than just like Black or African American, right? They might be like Jamaican American or Jamaican, something like this. So this really fundamentally on face value calls into question how our data systems are generated in the first place, and how something like, right, this is a data harmonization issue, how data harmonization is biased, therefore, when, we may have racial ethnic categories that are fairly limited and restricted to certain way of interpreting data. Now, imagine if you had a room full of people who belong to communities of color creating the data structure, they'd be like, like I'd be the one like, oh, you can't lump me with others. Like, I'm an Asian American, I'm an Indian American. Like, let's talk about those categories, right? Like, when you get those people into the room, probably you're going to start having this more comprehensive representation. And so, kudos to N3C that they've gone back and done the hard work to re-correct a lot of these categories. And this slide just compares the missingness in race ethnicity for different large data sets. So American Community Services using the census related data has almost no missingness. But CDC data has considerable amount of race ethnicity missingness. And this comes back to what I was talking earlier. It's at the jurisdiction level. And so if you may remember early on in the pandemic, King County, which is from Seattle area, was one of the few places that was reporting on outcomes race ethnicity because they've collected that for decades and have been reporting that. So they easily had infrastructure ready to go when COVID hit. While a lot of other jurisdictions, even now, don't collect this data disaggregated by race ethnicity groups. And a further kudos to King County, they also collect birth country status. So we know, for example, within the African American category, who are African born versus US born, for the Latino community, who is US born versus born in Mexico or elsewhere. I wanted to also highlight the rurality domain team that's done really great work. It's led by a colleague named Jared Unzolan at University of Nebraska Medical Center. And, here they show distribution of COVID cases with a heat map. You can all appreciate like all of Indiana state is dark red. It's not because Indiana had more cases. It's because Indiana has a state level electronic health record repository that documents every single COVID case that happened in the state. So this is, again, you need to question where data comes from and what are the biases that are baked into where your data is coming from in the first place. But they've done really great work to show disparities by rurality status. So this is an early work that showed how COVID-related hospitalization, oxygen support, et cetera, are all differential by rurality status. And then they look at post-vaccination breakthrough COVID-19 infections and show a similar trend that urban adjacent or rural areas tend to have higher post-vaccine breakthrough infections, as well as higher vaccine hesitancy. A lot of you can probably resonate with this finding from where we live. I'm going to shift my focus to what our HIV team has done to date. So I'm going to go into a little deeper here with our team, where we looked at, again, as I mentioned, we were grateful to get this R01 looking at the collision of HIV and COVID, and led by Eric Hurwitz and Kara Varley, have done some interesting phenotyping work where we've identified nearly 250,000 people living with HIV in this data set with N3C. Also a PrEP cohort, as well as a post-exposure prophylaxis cohort. And just on face value, right? Pure demographics, you can see that there is overrepresentation of Black, African-American, non-Latinx people among people living with HIV and N3C, which unfortunately mirrors nationwide trends. And so this was our R01, where we had 3 study aims. Aim 1, to look at the impact of COVID on HIV. Aim 2, to look at the impact of HIV and COVID. And then Aim 3, to understand how the emergence of COVID pandemic changes the trajectory of our addressing the HIV epidemic. We have a national guidance called Ending the HIV Epidemic, EHE initiative. And so we wanted to show how the trends varied at the jurisdiction level. So on the first one, where we're looking at the impact of COVID on HIV, a lot of this was was inspired by our initial work in our team by Jessica Islam, who showed the disparities in HIV and COVID. So purple is people who have people living with HIV and COVID. And then next gray bar is HIV negative with COVID, and the dark gray is HIV COVID, but without HIV positive, but without COVID. And you can appreciate that that among minoritized communities, so non-Hispanic, Latinx, Black, Latinx, and Asian American communities, you have a disproportionate burden of the two overlapping. And so they've gone on with the help, Jessica, with Eric, to look at area level SDOH intersecting with HIV. And so what we're able to appreciate here is that, again, so we're looking at, total people in this analysis that's stratified by HIV status, who had COVID-19 related hospitalizations as one of our severe outcomes for COVID. And you can see people with HIV just have a higher proportion of hospitalizations, but it's far more dramatic among Black and other racially minoritized communities. I know the graphic is really small, so I'm not expecting you to be able to look at any of it in detail, but we found that higher average household size was actually protective against COVID-19 hospitalization. So we know it's actually worse for getting incident COVID, but maybe having the social support, et cetera, prevents you from being hospitalized. Mean commute time was associated with higher risk, and we know that a lot of poorer communities, minoritized communities, live in areas that have longer commute, transportation, bus routes, train routes to work, wherever else they need to go, and that higher percent smoking. So these are all area level measures. They're not at the individual level, area level. We're associated with higher risk. And the effects tend to be highest among Black African American communities. We thought, well, this, N3C proposes a really interesting moment to understand SDOH at multi-levels, because it also has data from Epic Wheel, which is an individual level SDOH tool. So it asked, you have the option. So the EHR that uses Epic has the option to deploy parts of the Epic Wheel. So have questions on food insecurity, smoking, economic instability, housing instability, transportation, et cetera. And so N3C has gone through the effort of harmonizing this data as well, with the help of Charisse Madlock-Brown, who I mentioned before. And so it's a limited number of data partners. So instead of the 80 plus, we're now down to 19. So what our team did was we identified the issue by the question, at the question level, and then we categorize them according to the Healthy People 2030 SDOH framework. And so you see a visual of the different smaller categories, and then here the visual conveys as we categorize them according to the Healthy People 2030 framework. For race ethnicity distribution among people with HIV and then without HIV. And you can appreciate, for example, for economic stability, that larger green box represents Black African Americans. So a larger proportion of those are indicating economic stability issue or instability. And so since it's an EPI talk, I thought, and an EPI group, I added some tables with estimates. So table 1 is a model where we do what we call hierarchically nested model. So we have like an unadjusted crude model for 1, where we look at the SDOH vulnerability and COVID-19 related hospitalization as the outcome. And then in model 2, 3, and 4, we sequentially add more variables. And you can see that the relationships between the SDOH vulnerability persists despite accounting for age, race, ethnicity, sex, clinical comorbidity burden, which we use the Charlson Comorbidity Index here for, et cetera. And then in table 3, we stratified it by people with and without HIV, and you're still appreciating in the without HIV across the board, these associations persist through unadjusted and adjusted models. In the HIV, we're only seeing the economic stability domain persist. And then, you know, what I find really interesting in this work is that when we had a multivariate model where we added all the SDOH domains as well as our covariates, including HIV, what I find particularly interesting is that compared to the Black versus the white, we're actually seeing a protective effect of HIV infection among white communities. I think that's a really interesting finding, whether it's a juxtaposition of being Black and having HIV versus being white and having HIV, whether, you know, having the HIV somehow, you know, we do a lot of good access to care, ironically, once you're diagnosed with HIV. So if that's creating some differential protective effect amongst the whites versus the Blacks, you know, lots of different possibilities. But I thought this was a sort of a provocative finding that, of course, needs to be replicated. You know, and we used this paper to highlight an idea of precision public health. Yeah, I come from a clinical practice where we talk about precision medicine, and sometimes I get so annoyed because I'm like, who in low middle income countries or resource limited settings, even within the US, is going to have access to precision medicine? But I'm really excited about the idea that precision public health is a more equitable and accessible form of precision work that we can use. And I think some of this data can go towards arguing for that. We're doing some machine learning, statistical learning work in N3C for HIV. So Sandra Saffo, a biostatistician at University of Minnesota, has led a lot of this work here, where we're showing that different factors load differently for different racialized groups among people with HIV. Our second aim had to look at the impact of HIV on COVID. And Jing Sun has done interesting work using machine learning akin clustering approaches, where she's finding that factor loading for different comorbid conditions, which is really big in HIV, because a lot of the comorbidities like mental health and substance abuse predispose people to getting HIV. And once people have HIV, there's accelerated aging and inflammation that lead to higher risk of cancer, diabetes, heart disease, stroke, etc. So clinical comorbidity burden is huge in HIV, and she's doing some of this work to understand, you know, how do different clusters of comorbidities come together to affect people with and without HIV differently. Jennifer Ross at University of Washington, who does a lot of mathematical modeling in infectious diseases, is really interested in trying to use the estimates from N3C to generate more generalizable estimates for the country. So N3C, by definition, I didn't cover this so much, is predominantly a hospital-based electronic health repository, because most of the data partners are like UAB. They're large medical academic centers. And though a lot of the primary care sites like OCHIN or the Indian Health Services contribute data, it is still outsized by the amount of data that's provided by academic medical centers and inpatient data. And so she's been trying to use this population attributable fraction approach to try to see if we can use some of these estimates and weigh them in ways to make them more generalizable for understanding the impact of COVID on HIV, both in terms of infections, but also vaccination. And our third aim has been led by Bohdan Nosik, who does compartmentalized transmission models for HIV. So we're trying to understand, you know, there's been a lot of concern that at least initially the COVID epidemic interrupted access to care for people in HIV, just like other chronic conditions, but also significantly interrupted prevention services. So HIV testing, provision of pre-exposure prophylaxis prep, etc. And so we've done one of this works. I'm sorry it's projecting so poorly and is tiny. That tiny part I knew, but this was to just give you some sense. We've looked at pre-COVID, then early initial COVID pandemic, and then later stages for HIV testing data in N3C. And we're seeing major step-offs in the initial pandemic and some of the trajectories being different, even during the later stages of COVID. I'm embarrassed to acknowledge, but this is probably well aware to many of you, that the South lags behind in HIV testing throughout. You look for the total versus the three different racial ethnic groups later, and you can appreciate this is the South. You can see some of the West trajectories are really nicely upward, which is what we would like to see as all public health practitioners. But here in the South, there are even some like that initial one, the estimated was actually declining. You know, the initial model suggested the HIV testing was declining and hasn't been significantly increased since the pandemic. Okay, I wanted to save at least 10 minutes for more question and answer. So I'm really glad we're tracking well. Some of these I've already mentioned as challenges in community engagement. One of the things we failed at is technology literacy. So we use a lot of collaborative documents like Google Docs, and I can't tell you how much we have to work hard with our community partners to get them to do that, how we have to work hard with them to fill out invoices so they can get reimbursed. These are, you know, really small things on one hand for those of us who have a lot of computer or technology literacy, but it's been really a huge element of our work. And so I would love to hear how other people are doing this that are better served for community members. For some of our big data SDOH work, I think one thing we've been proud that so much of our work has been led by people who belong to minoritized communities. So we've had really good conversations like, do we do stratified analyses by race, ethnicity, right? Where the analyses are among Black people, among white people, as opposed to where we modeled them together. Who do we pick as the reference category? You know, like, are we going to pick white people without HIV? And there is an analysis where we've chosen that, right? Despite my initial initial reaction, we shouldn't do that. But there are moments where we said, you know, that is actually the question, like, are there disparities in access to, this is for a project where we're looking to access to COVID-19 therapeutics, so to remdesivir and Paxlovid. And we're saying, okay, we actually want white people without HIV to be the reference group. And so, yeah, it's been a lot of learning in how to think about race, ethnicity in these models. And, you know, coming back to, we're working at the SDOH level. A lot of our future work is looking at structural determinants. So we want to understand structural racism as well as structural sexism, structural heterosexism, or transphobia, homophobia. There just aren't great measures for this, and a lot of the measures that exist sort of recycle some of the SDOH measures. So it's really frustrating conceptually working in this area to think harder about how do we, like, if we were to computationally interested in this, how do we measure and utilize structural racism measures? One of the, you know, initially we started off, I just in time for Thanksgiving, this pie analogy. Some of you may have heard of it, where people talk about SDOH being the pie and structural racism being the baker or the oven. And I think more lately, our team has been thinking about this tree analogy where it's the interface of all that those structural determinants, right? So you have sexism. You may have xenophobia, right? If you're an immigrant community, xenophobia, structural xenophobia plays a large role in how outcomes may be determined for you. And so, you know, again, we're growing as a team. I'm learning and would love to hear more about how other people in related work do this. And lastly, you know, thinking about data analysis, I think we're on a very long path forward. I don't see the end to our journey, but we are trying to work hard on this. I will end there, and please get some thoughts or questions from all of you.